Hello everyone and welcome to this new debate as part of the chemotherapy courses at Gustave Roussy, which is celebrating its 40th anniversary this year. I am Dr. Natasha Naoun, a medical oncologist at Gustave Roussy in the genitourinary oncology team. I will be joined today by Dr. Filippo to discuss the use of PARP inhibitors in castration-resistant prostate cancer. If PARP inhibitors have already represented a revolution, especially in ovarian cancer, where they can be administered regardless of BRCA mutational status, conversely, in breast cancer and pancreatic cancer, they have shown a benefit only in patients selected for BRCA alterations. What is the reality in prostate cancer? First of all, olaparib is the only molecule approved in France in this context. Since 2021, it is used in monotherapy only in selected patients with metastatic castration-resistant disease. After exposure to a receptor inhibitor of the androgen pathway, and since September 2024, an extension of this marketing authorization in combination with abiraterone acetate prednisone for non-selected all-comers patients for whom chemotherapy with docetaxel was not clinically indicated. What do we find when we examine this data closely?
Thank you, Natasha. Thank you for the welcome. Well, indeed, before going back to the clinical trial data, I would like to quickly revisit the mechanism of action of PARP inhibitors. Simply put, PARP inhibitors act on DNA repair and specifically on the base excision repair system. As you can see on the diagram, there are many DNA repair systems. The
base oxygen repair, which includes PARP, of course, but also a very important system called homologous recombination that you see in the middle, and it repairs double-strand breaks.
How do PARP inhibitors work?
Well, quite simply, you know that in a physiological situation, a single-strand break will be repaired by base excision repair and by PARP. In a situation where a PARP inhibitor is introduced, well, this single-strand break will become complicated, leading to a double-strand break since it will not be repaired in the presence of PARP inhibitors. And that's where our rescue mechanism comes in, because homologous recombination will repair this double-strand break in the DNA. What happens in patients with a disease involving homologous recombination mutations is that once PARP is inhibited, there is no longer this rescue mechanism of homologous recombination for double-strand breaks, leading to cell death. And that's why that, as you said very well, Natasha, PARP inhibitors were initially developed in populations selected for DNA repair anomalies. That's convenient because in prostate cancer, up to 12% of metastatic patients present constitutional anomalies of DNA repair genes. And you can see that the most frequent is clearly BRCA2, which is a key protein in the homologous recombination system. And up to an additional 10% will acquire DNA repair system alterations in their disease. Factors otherwise associated with tumor aggressiveness, another reason to find additional therapeutic weapons for these patients. First trial, and you mentioned it again, which led to the approval of olaparib in 2021, it was PROfound. PROfound in a selected population where olaparib was randomized against lung cancer, a second line of second-generation hormone therapy, abiraterone or enzalutamide. Here in the design, we can see there were two cohorts. So two cohorts, all with patients having abnormalities of DNA repair, but cohort E1 with BERT anomalies, that is 1, 2, or ATM, that were suggested to make tumor cells even more sensitive to PARP inhibitors. So what we saw is a very clear benefit in progression-free survival in cohort A, not in cohort B. And then with the updated data from ESMO 2020, we also observed a very clear overall survival benefit in these patients. Design quite similar, TRATON 3 allowed us to see the activity of rucaparib in a similar indication with this advantage, which was to evaluate against a second line of second-generation hormone therapy or docetaxel for patients who have not previously received chemotherapy, which was a therapeutic standard, and the potential critique of the PROfound trial. What could we see in TRITON 3? Again, a benefit once more in a selected population, particularly for BRCA1/2. This is what we already saw in PROfound with laparibol, and therefore a clear benefit of PARP inhibitors in monotherapy here.
Where it becomes very interesting is that we
realize that there may be a rationale for synergy between PARP inhibitors and second-generation androgen receptor inhibitors. We know that PARP not only has actions on DNA repair, but also stabilizes proteins like the androgen receptor. And conversely, the androgen receptor has an effect on the transcription of genes involved in homologous recombination, and ultimately we may be looking at a partnership in crime between DNA repair and androgen receptor signaling, which provides a strong rationale to act on both pathways at the same time. This is the rationale for several combination trials in metastatic patients resistant to castration who have not previously received treatment with second-generation androgen receptor inhibitors. Magnitude was one of the first trials. You see that Magnitude combined a PARP inhibitor called niraparib with abiraterone acetate in a selected population. It is the first cohort that you see in green, as well as in a non-selected population, since I mentioned the rationale for being able to expand these combinations to non-selected populations. So Magnitude showed a benefit in a selected population, as you can see on the right, but no benefit in the overall population, which did not have a DNA repair anomaly. Is it an effect due to the tumor biology? Is it something related to the study itself or the PARP inhibitor itself? In any case, what is certain is that there have been concurrent trials, notably PROPEL. The interest of PROPEL is that we are dealing with a population that is this time non-selected. A randomization olaparib plus abiraterone acetate versus abiraterone alone in the same clinical situation.
In PROPEL, there is a clear trend towards a benefit in overall survival in the general, again, non-selected population. Same story for TALAPRO-2. I'll skip the complexities of cohort design with an unselected cohort that included both mutated patients, non-mutated patients, and then a cohort 2 that essentially included patients with DNA repair anomalies. And well, TALAPRO-2, which randomized talazoparib plus enzalutamide versus placebo plus enzalutamide, clearly showed a benefit in progression-free survival. The data,
not mature, which had been presented in terms of overall survival, had so far not shown a very clear signal, but very recently, a press release in October 2024 shows that TALAPRO-2 shows a benefit in overall survival in the overall study population not selected for DNA repair anomalies. In summary, the combinations of PARP inhibitors and second-generation androgen receptor pathway inhibitors show an undeniable benefit in BRCA-mutated cases, but there may also be a benefit in the general population, since, as mentioned, both PROPEL and TALAPRO-2 have shown a benefit in a non-selected population.
Thank you very much, Ronan, for the data summary. A question for you. In this case, do you think we should give up testing the patients, since ultimately we have a benefit in progression-free survival and overall survival, presumably, for the combination of talazoparib and enzalutamide?
So today, that is the question that arises with the accessibility of tests as well. It is clear that we will need the subgroup studies likely to determine the extent of the benefit based on mutational status. In my opinion, this is a key element in patient management. A key element also because we are in therapeutic spaces where we have more and more options. Of course, we largely have chemotherapy. It's also important to know everything related to targeted internal radiotherapy is developing earlier in the therapeutic lines, and we will potentially need selection criteria.
Maybe you'll enlighten us. Indeed, other therapies are also emerging to compete with these combinations in castration-resistant situations. And if we try to better select these patients, when we look in detail, and especially the subgroup analysis of the studies you just presented, Ronan, first of all, for monotherapy, for olaparib, we see that there were no significant results. For the cohort of patients who did not have DNA repair gene alterations, in TRITON, the patients were stratified based on the anomalies that affected both the BRCA or ATM genes. And finally, in the ATM population, one might have thought that it was part of the anomalies sensitive to this type of targeted therapy. The result was not statistically significant. When we look at combinations, notably Propel, which led to the market authorization we mentioned earlier, we see that there is a benefit in the overall population, but it seems mainly driven in terms of progression-free survival by the group of patients with mutated BRCA, since patients without BRCA alteration have a benefit for progression-free survival at the edge of statistical significance, and for overall survival when looking at the confidence interval includes 1. So actually there are no significant results in overall survival in this subgroup, unlike as you see in the BRCA mutated population. And possibly it is this population that pulls the overall population's result upward and thus leads to positive results for this study. In the specifics of TALAPRO-2, it is also considered that there is still a significantly greater benefit in the selected patient population. And when looking at the details of all the patients with alterations normally sensitive to this treatment, we see that there is a large disparity with ultimately only the BRCA patients, and especially the BRCA2 patients, possibly CDK12, who seem to benefit from the treatment, but not the other alterations.
Natasha, if I take your data, indeed there are some rare mutations on which we are going to have difficulty possibly having data with a large population. If the question is, without being provocative, but if the question is simply to add one more pill daily for the patient, is it really necessary to test everyone, as you were asking earlier?
So it's not just one more pill, because when we look at the toxicity data, even in monotherapy, we see 50% anemia. Half of these anemias are grade 3 or higher. There's also a higher incidence of pulmonary embolisms, even though there are no cases of pulmonary embolisms. Was fatal, there is still almost 5% of pulmonary embolisms versus less than 1% in the arm without a PARP inhibitor. And toxicity, we know notably from studies in ovarian cancer, a myelotoxicity with the occurrence of a case of acute myeloid leukemia in the experimental arm. In combination, it is exactly the same. We see an incidence of anemia, particularly significant anemia of grade 3 or higher, which is very important. And once again, a much higher incidence also of thromboembolic events, especially pulmonary embolisms, even if most of them are asymptomatic. And once again, 2 cases versus 0 in the standard arm of myelodysplastic syndrome and acute myeloid leukemia. When looking at TALAPRO-2, they are exactly superimposable. As Absunosan said, the data is entirely consistent with anemia of grade 3 or higher, 43% requiring transfusions and therefore day hospitals or even hospitalizations, risks associated with the transfusions themselves, not to mention again 10 cases of pulmonary embolism versus 3, 1 case of myeloplasia, 1 case of acute myeloid leukemia in the experimental arm. Moreover, this toxicity does not come with a gain in quality of life, so there is no significant deterioration in quality of life with the combination, but there is also no gain. It is comparable to what we do with an androgen pathway inhibitor alone. And finally, not counting beyond this cost in care, the total cost of these drugs, which are still expensive, in combination with hormone therapy, which itself has its own cost. And the benefit does not seem, at least in the general population, worth it by checks for all patients. And finally, the last thing is the design of these studies with a population that is no longer quite the one we currently know in a castration-resistant situation, whether in Propel or TALAPRO-2. Ultimately, few patients had received an androgen pathway inhibitor before the castration-resistant situation, whereas currently in the hormone-sensitive situation, all our patients are exposed to these molecules. On top of being difficult to apply, very few patients from the standard arm in each study were able to later benefit from a PARP inhibitor, while, as we have seen, between 15 and 20% of them have alterations that could make them sensitive to this inhibitor. So they did not receive this treatment whose benefit we have seen in monotherapy. Conversely, we also know that these patients respond less well to standard treatment and notably to second-generation hormone therapies, but also possibly to taxane chemotherapy.
Thank you, Natasha. So clearly, if I summarize what you say, let's still be cautious about generalizations. The benefit seems quite clear in mutated patients in this very specific population that has not received second-generation hormone therapy previously for their metastatic diseases. We will probably wait for the subgroups for really assert the benefit in overall survival and identify who absolutely needs this combination therapy. Then, of course, we are in a changing landscape with new possible combinations, new therapeutic options, and potentially lines that will move up gradually. So we will have to stay aware of the various advancements. I'm just going to make a brief aside to illustrate these new combinations. I show you here the example of Eslu-PARP, which has been combined in patients with castration-resistant metastatic prostate cancer. PARP inhibitors, which we have just discussed extensively, and targeted internal radiotherapy, so lutetium PSMA that, as you know, delivers beta radiation to cells expressing the PSMA. You can see here that in this phase 1 with different dose levels, well, we have extremely significant responses on PSA 50, notably with almost 70% of responses. So response rates, data that are very interesting. Of course, this is a phase 1. We will need to see the long-term survival data and the more advanced phases, but it is part of the promising combinations. Being mindful, of course, of the hematological toxicity, which Natasha, you discussed extensively earlier. And then beyond the innovative combinations, simply put, as we said, the lines that are going up. And today we have phase 3 in situations of castration sensitivity. That's the case with Talapro-3, Talazoparib plus enzalutamide. It's the case with so Amplitude Niraparib plus Abiraterone. Again, in the study design,
it's testing for DNA repair anomalies, which will allow us to have data that is contemporary and will also be compared to a standard of contemporary treatment, since we will be in a situation of comparison with the emitters of the androgen receptor axis in a castration-sensitive situation.
Thank you very much, Ronan. So indeed, we are waiting for the data from these ongoing studies, but also the details, particularly the subgroup analysis of Talapro-2, which are expected to be presented in a few weeks at the SCO GIU 2025, of which we will not fail to provide updates as usual also via the Gustave Roussy team. And we also remind you of the importance of continuing to test patients both for screening the identification of germline mutations and thus for the patient's relatives. And apart from the predictive aspect for treatment, which may be less significant now with these associations, possibly in the general population. However, our role remains prognostic because these patients respond less well to other lines of treatment. And so this information remains useful for their management.
And for the family potentially.
Absolutely. Thank you very much, Ronan. Thank you, and thank you very much for following us for this debate as part of the Gustave Roussy chemotherapy courses. You will be able to find all the courses from the 2025 edition online on the GR Education website.